Good afternoon, everyone. I would like to thank the SMSNA and AUA for inviting me. It's good to be back with family, friends, and colleagues. I got no disclosures. I'm currently practicing in HMC Qatar. I would love all of you to come and visit someday. So, quick question to the audience here. How many of you encounter patients with ED, and then they ask you, hey doc, I want a testosterone replacement to treat ED? Okay, that's a lot, nice. Okay, second question, how do, routinely you ask for signs and symptoms of hypogonadism on your daily consultations? How much time does it take? Is it enough for the 10, 15 minutes that you're allowed, or does it take more than that? Probably more, if you're gonna talk about testosterone and all the exciting stuff. So yesterday, while I was rehearsing for this presentation, and then I opened my Twitter account, and I found this coming up on my ads. It's testosterone. It's for men 40 and above, and it's talking about testosterone as a treatment for ED. Imagine patients just looking through these, and they have the ease of ordering this in no time without understanding the effects of testosterone, whether it works with ED or not as a single therapy or a monotherapy. So what's the relationship between testosterone and sexual function? It's bidirectional. Low T will cause and affect sexual dysfunction. There's multiple tissues that are T-dependent. During fetal growth, phallus growth, the prorectile neurotransmitters from the brain, like dopamine, oxytocin, is T-dependent. Pudendal nerve that supplies the bulbocavernous and ischiocavernous is T-dependent. The cavernal parasympathetic nerves and the relaxation of the smooth muscle, they're also T-dependent. There's basic science that have proved this, that androgens enhance the expression of nitric oxide synthase. Others have shown that the phosphodiesterase activity improves with the presence of androgens on animal models. Also, the enhancement of the penile nerve function. And finally, the veno-occlusive erectile function. All these depend on androgen. With age, ED prevalence increases. Around age of 50, you got 15% of population have ED. It increases above the 70s and 80s to reach up to 100%. Interestingly, a study by Dr. Kohler almost a decade ago showing that ED patients age 40 and above, they have almost a 40% chance of, or prevalence of having hypogonadism, and that age is correlated with significant decrease in testosterone levels in ED patients. So what's the clinical evidence behind this? There's multiple systemic reviews and meta-analysis that support this. Bologna and colleagues have shown that testosterone is more effective when used in younger patients and in severe cases of hypogonadism as a treatment for ED. Another meta-analysis based on the IEF questionnaire by Corona and colleagues showed that sexual dysfunction is a manifestation of testosterone deficiency, and that testosterone therapy alone could be used as a potential monotherapy in milder degrees of ED. Also, there's multiple studies have shown how PD5 non-responders can shift to responders once you normalize their testosterone levels with at least 3 months of testosterone replacement. So the 2018 guidelines, that's the latest that we have. We need to appreciate validated questionnaires to use with our patients in the clinic. ED is a risk factor for cardiovascular. If you haven't had a cardiovascular event, you'll probably have one in the next 2 to 5 years, so get that checked out. Morning testosterone is crucial to get measured for all ED patients that come in your clinic. With treatments, I'd like to speak with the patients, tell them we have 3 pillars for treatment: PDA5, intracorporeal injections, and penile prosthesis. 2 adjuvants like the vacuum erection device and the intraurethral aprostadil. And of course, the new regenerative therapies coming up: shockwave, PRP, stem cells, and radiofrequency. According to the guidelines, they're still investigational, but there's multiple prospective studies ongoing at the time being, outlining their safety, efficacy, and also their regimen to use. We all prescribe PD5s. What I tell my patients specifically when I prescribe sildenafil, take care, you need to take it on an empty stomach, right? Despite some reports saying you can have it with food. Also, visual disturbance. A patient wants to know if things are going to turn blue if you start taking sildenafil. With tadalafil, I have found patients coming and tell me, hey doc, the next day the pill works wonder. It's way better than the first day. And I always counsel them about the muscle pain and the stuffy nose that usually happens with tadalafil compared to other PD5s. You should consider mental health if you suspect Mental health referral if you suspect performance anxiety. Lifestyle modifications are very important for such patients, and also in patients with combined testosterone deficiency, you tell the patients if you get your testosterone checked and normalized, probably the PD-5s and other treatments will work better. With regards to the testosterone guidelines, having 2 early morning samples a week apart below 300 is low testosterone. Having the signs and symptoms of hypogonadism means a clinical diagnosis of testosterone deficiency. And again, we don't have any validated questionnaires yet for testosterone in order to stratify patients and monitor symptom response, but this could be changed in the near future. With testosterone, you usually order other labs like LH, and if it's low, you order prolactin. If you find a high prolactin, then probably you will consult an endocrinologist. Before starting testosterone replacement therapy, you need to inquire about the fertility potential of the couple. If they're willing to have kids in the near future, probably you will have to discuss how exogenous testosterone affects spermatogenesis to some extent. Before TRT or testosterone replacement, you usually measure the estradiol levels, especially if they have gynecomastia or breast symptoms. You measure the hemoglobin and hematocrit levels for the risk of polycythemia, and PSA in men above 40 to exclude prostate cancer diagnosis. Counseling about lifestyle modifications is very important. I have seen patients double their testosterone level by losing weight. Low testosterone, same as ED, is a risk factor for cardiovascular, so you need to counsel your patients about it. And again, emphasize about the fertility impact. So there's some myth you need to break. There's no definitive evidence linking testosterone replacement therapy with prostate cancer, with DVTs, thromboembolic events, cardiovascular risks. And you always want your patients to keep their testosterone in the mid-range normal. You don't want it super high or like low normal. If you had a recent cardiovascular event, you wait 3 to 6 months before starting your testosterone replacement. And for couples trying to have kids, there's always aromatase inhibitors. There's the HCG, and of course, there's the SERMs, clomiphene citrate and tamoxifen. We all know the different forms of testosterone, whether short-acting injections, long-acting injections. We have the oral forms with the variable absorption and multiple tablets per day. There's the buccal transdermal. There's the androgel with the risk of transference to your partner. There's the subcutaneous pellets. And of course, there's an Testosterone gel that reports say and have proven that it has very minimal effect on the gonadotropins, aka preserves spermatogenesis, despite being short-acting. We have to manage patient expectations. We tell them, expect your symptoms to improve within 3 to 12 weeks. It could take longer depending on your T levels and depending on the symptoms that you experience. If you're looking for improvement for erectile dysfunction, it could take up to 6 months before you see any changes. So follow-up is very important, and it's a big hassle to discuss. It depends on the type of testosterone form that you are giving the patient. Could be 2 to 4 weeks, 4 weeks, after 3 to 4 cycles. It depends. And then after the initial follow-up, you got follow-ups every 6 to 12 months. So how to improve the patient experience, how to be more efficient, utilize your APPs and PAs and office staff, let them help you with the history taking. That takes some time. Print questions for your patients to fill while they're waiting for you in the clinic. Have a favorite set of labs to order once you suspect testosterone deficiency. Make a ready-made schedule for testosterone patients follow-up. It could be telemedicine, very convenient for you and them. Have patient pamphlets ready to help the patient choose the best form of therapy. And also train your residents and fellows about the latest updates and management guidelines. So a take-home message here is that androgen plays a key role in the overall sexual and erectile function. Each form of testosterone has pros and cons depending on the convenience, cost effectiveness, and potential side effects. The choice depends on the doctor's recommendation and the patient preference. Men should not take testosterone as a monotherapy for ED. Potentially, it could be effective in 3 cases: young, mild ED, and severe hypogonadism. Adding a T replacement could change a non-responder to a responder, and the recovery of the sexual function usually takes 3 to 12 weeks. At least, depending on the baseline T level and the symptoms. These are my references. I would like to thank my PDs, Dr. Magzouf from HMC Qatar, Craig Niederberger from UIC Chicago, Dr. Ron Wong from UT, and MD Anderson in Houston, Texas, for whom I would be standing here. Thank you for your attention.